All right. Welcome to today's webinar, the top 3 workers' compensation injuries and illnesses, an employee-centric approach to recovery. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts, in collaboration with Dr. Scott Cooper, Dr. Erin Watson, and Dr. Derek Davidson of Pioneer Spine and Sport. We're excited that you've joined us for this presentation. My name is 𝐒𝐞𝐬𝐬𝐢𝐠𝐡, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay, along with a link to a short survey. Again, we're excited to host today's webinar and look forward to the next one that we'll be having in a couple months. To kick us off, I'll pass it to our host, Cynthia Bourbeau. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, also known as MLCC, and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 3 decades.
Hello, and I'd like to just say thank you for joining us today and welcome. Now, before I hand it over, I'd like to share a little bit about the Injury Insight program. Injury Insight's a 4-part webinar series designed to educate claims professionals, HR professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, and diagnoses, both common and uncommon, within workers' compensation. This program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, the potential obstacles, and answer your toughest of questions. So get your questions ready. For this session, the top 3 workers' compensation injuries and illnesses, an employee-centric approach to recovery. We're pleased to have physician specialists Dr. Scott Cooper, Dr. Erin Watson, and Dr. Davidson of Pioneer Spine and Sports Physicians. Now, I have to tell you, these physicians are wonderful, and I've enjoyed working with Pioneer Spine and Sports over the years, but they're very modest. So I have very brief bios to read to you regarding each of them. Dr. Scott Cooper is a physiatrist and has been with Pioneer Spine and Sports Physicians since completing specialty training at the Rusk Institute of Rehabilitation Medicine at NYU. He is on faculty at both UMass Medical School and Tufts University School of Medicine. Dr. Erin Watson, also a physician with Pioneer Spine and Sports, focuses her practice on ailments of the spine, spasticity, amputee care, and musculoskeletal dysfunction. Dr. Watson is a doctor of osteopathic medicine and earned her degree from Kirk School's College of Osteopathic Medicine. She is an avid runner, Spanish speaker, and Green Bay Packers fan. Dr. Derek Davidson, also a practitioner with Pioneer Spine and Sports, earned his doctorate of osteopathic medicine from the University of New England College of Osteopathic Medicine. Dr. Davidson also attended the University of Connecticut, where he earned both a bachelor's and master's degree in physical therapy. When he's not practicing, Dr. Davidson spends his time enjoying his 2.5-year-old daughter and is awaiting the arrival of his 2nd child. Dr. Cooper, I'm going to pass it over to you to get us started.
Good afternoon, everybody, or good morning, whatever the case may be, depending on where you're located. I've been doing this for enough years, and I've done it enough times so that I can't really give a talk without explaining first what it is exactly that I do. And as soon as I figure out how to move the slide, I will do just that. Although, sorry. There. Although I realize this is a pretty sophisticated crowd, so maybe a better question, rather than what is a physiatrist, would be why is a physiatrist the best clinician to be involved with an occupational injury? And the answer is simple. Physiatrists are trained specifically to assess injuries with an emphasis on function, based on our knowledge of musculoskeletal and neurologic conditions. After an initial consultation, a physiatrist should be able to formulate a specific diagnosis, or at least a differential diagnosis, including identifying a pain generator or the source of the patient's primary discomfort. Based on that information, a physiatrist should be able to generate a multidisciplinary, holistic treatment plan, and even to establish whether there are activity restrictions relative to the patient's employment. Specifically, we should be able to explain what activities a patient can and cannot do relative to their injury, and establish a rough timeline for how a patient is going to improve, how they're going to return to normal function, and how they're going to be able to return to their usual occupation. I think we probably all are familiar with the research that's shown quite convincingly that there's a direct correlation between patients being taken out of work, especially in an open-ended fashion, and long-term disability. Our job is to manage those expectations, to reassure patients that they will be able to increase their function and return to normal work, all while keeping as a first priority the well-being of the patient and a good outcome. So I think we have a poll, and I'll give everybody a second to look at the possible answers. So hopefully by the time we're done, everybody will have chosen D, none of the above, because cervical injuries are, oh, there we go. Because cervical injuries are injuries like everything else. We identified the pain generator, we identified the injury, we make the diagnosis, and we establish a treatment plan, and patients do well in general. The neck is not a black box. We can identify which structures are causing the pain, and we can address them. And that's what we're going to talk about now. Gigi, I am having trouble advancing the slides. Oh, wait, I got it. So, so in looking at the neck and specifically cervical injuries, there are basically two types of injuries, axial and radicular. So axial pain means that pain, it basically means neck pain. It means that the symptoms that the patient is experiencing are generated in the neck, and they stay in the neck for the most part. Radicular symptoms are those that go into one or the other or both of the upper extremities. So sources of axial pain, neck pain, are not that complicated. There are really relatively few of them. There's soft tissue strain, of course, and that is, we've all heard the term cervical strain. We also have all heard the term chronic cervical strain. And I'm here to tell you that that is an oxymoron. There is no such thing as a chronic strain, because a strain is stretching or injury of muscle tissue. Muscle tissue generally takes about 2 to 4 weeks to heal. So if patients are symptomatic beyond that length of time, there must be something else going on. It could be a sprain, it could be joint pain, it could be even nerve pain, but it's not strictly a strain, it's not strictly muscular. Very common cause of neck pain are the facet joints, and facet joints are located on either side of each level of the spine. They're in the cervical spine, and that's what I'm going to be talking about, but they go throughout the rest of the spine to the lumbosacral junction. And then the last major cause of axial neck pain are discs. And one point I want to make about discs are that discs can cause pain in 2 different ways. One way is by becoming herniated or bulging and causing compromise of an adjacent nerve root. That causes radicular pain, and in that case, the disc itself is not really the painful structure. The other way that discs can become painful is if they become damaged or degenerative, in which case they can cause axial pain, neck pain. And the other thing that's important to keep in mind about discs is that the vast majority of them do become degenerative or damaged at some course along a patient's life, but they very infrequently actually cause symptoms. Most disc abnormalities that we see on MRI studies are really irrelevant. So then the question may come up, if we get an MRI for axial neck pain and it shows that there's disc degeneration, it shows that there's disc bulging, maybe herniation, it shows that there's facet joint arthritis and there are nerves that are being compressed, how do we know which of those things are causing the pain? And actually that's a trick question because we don't get MRIs for axial neck pain. There's no reason to do that. Very rarely would any advanced imaging actually change the treatment plan if the symptoms are localized to the neck and if the neurologic exam is normal. So for axial pain, in the initial phase, we want to focus on relative rest, meaning not bed rest, not stopping all activities, but stopping the specific activities that are going to impede the patient's normal healing. We may initiate physical therapy, although we generally try to not do that immediately. Usually we wait about 2 weeks, reassess at that point, and if there seems to be mechanical or musculoskeletal issues that can be addressed with therapy, then we implement it. Exercise-based physical therapy is generally not helpful for neck injuries. Strengthening the neck muscles really has never been shown to be very helpful. Stretching neck muscles has to be done very carefully, and in my experience is just as likely to cause more problems as it is to solve things. So physical therapy is really most helpful for cervical conditions when it's hands-on and when it's limited. Oral and topical medication certainly can be helpful, muscle relaxers, neuromodulators, anti-inflammatory medication. But then if symptoms persist and patients aren't able to progress their activities because of pain, then the option of injections does exist. Trigger point injections, I personally do those very infrequently, but they can be helpful for persistent muscle irritability, not strain, but irritation, and facet joint injections. So I'm going to try again to advance the slide. Come on. Does not want to advance. Gigi, can you advance the slide? Oh wait, I just saw it. There it is. The arrow comes and goes. So this image is great because it shows us on X-ray and also on a model similar structures. So looking at the X-ray, you can see here, this is a lateral projection. And by the way, you can see, I just want to show one more thing on this image. You can hopefully notice that this patient has a nice curve to their spine. In this X-ray, that curve is lost. So this patient has straightening of the normal cervical spine. Radiologists love to say that that's caused by muscle spasm. I don't know where that assumption came from, where that conclusion came from, but I dispute it. I don't believe that straightening of the normal cervical curve is caused by muscle spasm, and that's very easy to prove. And the way I can prove that is because patients who have straightening of the normal cervical spine always have straightening of the normal cervical curve. Straightening of the curve in the cervical spine is most likely caused by intervertebral disc disruption and abnormality. If it were caused by muscle spasm, then it would normalize because muscle spasm is not generally a continuous, chronic, never-ending process. And patients who have that kind of straightening virtually never go back to having a normal curve. I will tell you, the only patients that I've seen who had straightening and actually went on to have a normal curve underwent total disc replacement. But it's not caused by muscle spasm. So in any case, we see that there's disc narrowing at a couple different levels. And in the back here, we see the facet joints. And if we need to inject the facet joints, then we do so with a specific purpose in mind. We don't just inject facet joints because the pain is still there and we don't know what else to do. If we determine that we're going to do an injection into facet joints, we do it with the expectation that we're going to learn something. Facet injections should be diagnostic as well as therapeutic. So on this side, you can see that we injected, this is a C2-3 facet. This is a C3-4 facet, C4-5 facet. We generally inject 2, maybe 3 facet joints at one time. And this is 5-6 and 6-7. When we inject those joints, we inject anesthetic. That's mostly the diagnostic part. Somebody comes in with 8 out of 10 pain and limited range of motion, and we inject their facet and anesthetize it. And for 3 hours, they have very little pain and full range of motion. We know that the facet joint is the major pain generator. And the opposite is true as well. So the other type of pain that's very important in cervical injuries is radicular pain. And that means pain from the neck that radiates into the extremities. So the most common source of that type of pain is nerve root irritation that's caused by either a herniated disc or degenerative changes like bone spurs, foraminal narrowing caused by osteophytes, or central spinal canal compromise. Occasionally, facet joints can cause something of a radicular pattern, but facet pain, even if it extends into the shoulder from radicular pain. Treatment of radicular pain is generally a little bit more aggressive than axial pain. And this image shows us, that the spinal canal is right here where the spinal cord lives. And at each level, this is kind of a bird's eye view. At each level, a nerve root exits. And if we need to address a nerve that's irritated, we can do a transforaminal injection, which is what's shown here. So there's black contrast that's outlining the nerve root. Again, we should be learning something when we do an injection. And epidural injections, which transforaminals are a type of epidural, are really only done when more conservative measures have been unsuccessful. But this is a way of coating that nerve with cortisone. And that can be very, very effective in reducing the inflammation around the nerve root, reducing pain, and allowing progression of function. And then the next image is an intralaminar epidural injection. In this case, we have a needle that's kind of placed in a midline approach posteriorly, and the medicine will go, and what you can tell is that the medicine, instead of targeting that one nerve root, the medicine is going to go on both sides of the spinal canal, and it will go to multiple levels. So it's a little bit more of a shotgun approach to treatment. And we don't learn as much by doing intralaminars, so it's not the procedure of choice, but it can be for reasons that nobody has really established. Sometimes radicular pain responds better to an intralaminar than to a transforaminal. In other cases, it's the converse. One last thing I just wanted to mention that's a total non sequitur is spinal cord stimulation. We have a spinal cord and DRG stimulation program at Pioneer, and those are modalities that should be used as a last resort only. We never think of that unless we have a very difficult situation where pain simply can't be controlled by other means. Oftentimes, these are patients who have had surgery and have recurrent pain or don't do well, have post-laminectomy syndrome. This is a study that I think was done quite a while ago, but it still is considered a standard and is actually one of those studies that helps us in decision making. And the North study, what it established was that in patients who have surgery and then develop recurrent radiculopathy, they do, their outcomes are better and their utilization is less and their cost effectiveness is much greater in general with spinal cord stimulation than with repeat surgery. And I think my time is up, so I'll wait and see if there are any questions at the end. Thank you.
All right. Dr. Watson, I'm going to pass it on to you.
All right. Hold on. Hi, I'm Dr. Erin Watson. I have a poll question for you. Right? Yeah. And I'm just going to go ahead and say something about being a DO. Back in the 1800s, there was a lot of, oh good, we have something to talk about. Poll question came up. There was some unfortunate manners that we were treating patients back in the 1800s. An osteopath came up with a new way of treating, which involves some manipulation, kind of what we might think a chiropractor does. And over the years, I think MDs and DOs have really melded, and we've become, we've all come to the same conclusions now. But the schools are still separate, and there's still just slight differences. But in the United States, it's basically the same. So I just wanted to bring that up because Dr. Davidson and I share this. All right, low back injuries. This is going to piggyback, onto what Dr. Cooper said. All right. So when someone shows up to our office with low back pain subsequent to something that occurred at work, we need to understand where it's coming from, as was stated before. Some people have already been seen in a urgent care or primary care office and will come with an x-ray, MRI, but very important in the whole process is the physical exam and getting a good history and understanding how the injury occurred so that we can identify the pain generators. A lot of people do come to have back pain with work injuries, not just out of something very dramatic, such as a lifting injury, but more recently we've had a lot of chronic computer work, sitting, ergonomic setups from home that are contributing to the symptoms of low back pain. So it's been kind of an interesting shift here during the time of COVID. So similar to what Dr. Cooper said, we have the actual spine itself, but then we also have all of the surrounding tissue and network. But given their pain, most back pain will resolve, so we need to have some restrictions so that we don't continuously irritate the injury itself. All right. Types of, this is going to sound very similar to Dr. Cooper's conversation, but I will try and add tidbits of information here. So similar axial pain, but in addition, you can have the strains, the sprains, as he previously discussed, and the discogenic, acute versus chronic. And this is where it's been interesting because there are some injuries that occur even lower, especially in strong lifting injuries into the gluteus and the sacroiliac joint. So there's muscular and ligamentous injuries that can occur in the sacrum and in the pelvis that can look like a low back pain, but actually be a more inferior injury. So as previously stated, we want to make sure that the patient will recover from the injury with some activity modification. This is the light duty, and you know, it depends on how the patient presents as to how much, what exactly number that would be, like lifting restriction, bending, stooping, etc. Oral medication usually focuses on anti-inflammatory and neuromodulation, depending on, muscle relaxation. Physical therapy, I think in contrast to the cervical spine, we might actually start that sooner in the process, and then injections, and that can be epidural, muscular, or facet, as previously stated. So then there's the radicular pain, again, similar to what Dr. Cooper said. Disc disruption, acute, like a herniation or a tear or a disc bulge. In general, the people who do a lifting technique where they lift and twist, or when we do some kind of like a shoveling or unregulated lifting technique, those are the ones that are at most risk. That's why we have the OSHA and all those instructions as to proper lifting technique. It's to avoid this exact thing. So 2 planes of motion with weight is the perfect unlocking of a disc, and that is gateway to disc issues. So in this pretty simplified picture, you can see that this disc is having some, so the jelly of the donut is leaking out towards that nerve and causing a stain on that nerve root right there. The actual pressure of the inside of the disc, the actual chemical, can be very irritating and cause quite a bit of pain. And this is the stuff where people will call it sciatica, though sciatica is really just a word that means pain into the leg. It doesn't necessarily have to be that the sciatic nerve lesioned. It can just be nerve pain into the leg, and it could be femoral. Most people will complain of behind the leg and to the outside of the leg. Again, similar treatment plans. Only in the most severe cases would we suggest surgery. Those people where you would urgently encourage someone to go to surgery are those who have lost function of a limb, are losing strength. And then anytime that you have somebody who's lost bowel or bladder function, those are the do not stop it, go, don't come to physiatry, go immediately to the ER kinds of folks, because you want to preserve the function of those nerves as much as possible. So there are some urgencies and emergencies, and hopefully that's recognized. All right, common goals. So things that we definitely want to, this is a silly picture. Proper lifting technique, as I previously said, but the goal is to return to work as rapidly and safely as possible. The other goal is to remain at work throughout their treatment and rehabilitation, even in the limited capacity. The longer they're out of work, the longer they stay out of work. And we all understand that. I think there is a difficulty in some jobs not being able to accommodate the restrictions, but you know, our goal is to not have them leave the work. All right, you guys can read. There are people who are in more laborious jobs who have already had a lumbar surgery because of a previous injury. Repeat surgery or going back to the surgeon doesn't usually encourage a very good outcome, and surgery tends to beget surgery. So we try to keep that on the shelf as long as possible. And like I said, the nerve damage. And Dr. Cooper did mention the spinal cord stimulation, something that we would hold on, but for someone who may have already had the spinal surgery, this is an option. Most low back injuries do improve with conservative measures. And that's the activity modification, the muscle recuperation, the strain. Activity modification, light duty, allow the injury to actually heal. So the difficult part is, again, here we've had a lot of people who are seated, and the prolonged sitting without change in position has actually exacerbated some other issues for some people in the time of COVID. So that's been an interesting thing to try and get an ergonomic setup in a person's home, unique here lately. And that's it. I'm unfortunately saying a lot of the same things as Dr. Cooper, but happy to answer more questions at the end. But kind of a similar story, just lower. So that's what I got. Thanks.
Thanks, Dr. Watson. Dr. Davidson, you should now have control of the mouse. Except Dr. Davidson, you're also on mute. Just make sure to unmute yourself. Okay, I can move it to the next screen for you, and then also let's make sure we get you off of mute. And we're still not hearing you, Dr. Davidson?
Can you hear me now?
There you go. Yes, we can. Do you want me to go back a slide?
Yeah, that'd be good.
Okay. And we'll start here.
All right. So, yeah, so I'm going to be talking about soft tissue injuries. It's kind of a broad topic. In general, This is going to encompass kind of tendinitis, bursitis, that type of thing. You know, there are muscle strains out there as well. But, you know, in general, when it comes to workers' comp injuries, upper extremity tends to be the more frequent rather than lower extremity. Some examples of this are rotator cuff tendinitis, bicipital tendinitis, lateral epicondylitis, which is also called tennis elbow. I very infrequently see people who actually play tennis that have tennis elbow. It's usually from other things like repetitive stress at work. And Dequervain's tenosynovitis, which is actually inflammation of the tendon sheath. That's kind of an example where that little hand is there up there, and down that picture on the bottom is an example of a lateral epicondylitis. But the idea really is that tendon is structure that connects muscle to bone, and that area can get inflamed for various different reasons, which we'll talk about a little bit. So we can go to the next slide there. Oh, I got it. All right. Oh no, I think you have it. All right. Yeah, like I said, lower extremity is far less common in a workers' comp setting. In general, we see it in practice, but comp I see it less frequently. Some of the more common ones here are patella tendinitis, quadriceps tendinitis. You can see that little picture over there, kind of showing you where those tendons are and where they meet. And those can get strained and angry. Posterior tibial tendinitis, there's a little picture of that down right underneath towards the right. You can see that kind of angry tendon there that can show up occasionally here. And the Achilles tendon is a common site as well. There's a bursa under there also. Yeah, so we told you what a tendon was. I'm sure people know what bursa is, but a bursa is just kind of a fluid-filled sac that helps decrease friction between structures, so can get irritated for different reasons or various reasons. So we can go to the next slide there. So as far as causes and the signs and symptoms of these things, for the most part, when it comes to, in general, but especially in workers' comp injuries, it tends to be a repetitive stress injury. So it results from cumulative trauma. If you're doing the same thing over and over again, especially in a poor ergonomic position, or if you're doing it incorrectly, over time, you tend to stress those tendons and bursa, and it can show up as an injury. You can also have, and so risk factor wise, you know, poor ergonomic setup, or just being in general poor health, or being in poor condition can leave you at stress for this. It can also be from an acute injury, but I would say that usually, you know, even though there may be one inciting event, it typically is set up from repetitive stress, and then you kind of the straw that broke the camel's back, so to speak, and then they come in with an injury. The general signs and symptoms of these types of things are pain, obviously. That kind of is what brings people in. Area can swell. There could be decreased range of motion, sometimes some weakness. Now, the weakness is typically there because of pain, so they're self-limiting. If you have significant weakness, then maybe we're talking about something else, maybe a nerve injury or an actual rupture of a tendon. But that would dictate, based on our exam, how we kind of work that up and then go with further treatment. So we can go to the next slide there. As far as diagnosing these things, for the most part, it is a clinical diagnosis. I mean, you don't typically need imaging to diagnose a tendon injury or bursa injury. It doesn't mean that we don't get imaging. The imaging involved is usually to rule out other things. So it's not uncommon for people to come in with an x-ray if they've already seen an urgent care or something. They'll x-ray the area to make sure there's no underlying fracture or something like that. And especially if your exam is suspicious for a fracture, if they had a really traumatic injury, then you want to make sure that there's not something going on underneath. MRI is not something that we typically jump to unless they come in and they have significant, say with a rotator cuff, for example. You're examining, they just have a dead arm, a drop arm there, and you really think that that there's an acute rotator cuff tear, then an MRI might be indicated there. If you think that something's a avulse, but for the vast majority of these things, you diagnose them clinically and then treat conservatively. And it's based on a total exam. This is just a couple of little examples on the pictures. There are provocative tests for the different areas of injury. like we were saying here with that, this is a Finkelstein test where you kind of strain that tendon over the wrist, and it usually is painful. That can be painful in just about anybody. It's just not a comfortable thing to do for a lot of people, but that's one test. And then over here, it's just an example of doing some shoulder range of motion, trying to pick out some impingement. But again, it's based on a total exam, trying to really diagnose the area of injury and then kind of create a treatment plan from there. Go to the next slide there. So as far as the treatment, now I guess this is just more of a overview of the treatment. While the injuries vary from site to site, they're all different injuries. The general outline of how you treat them tends to be fairly streamlined. So really the biggest thing is early identification and kind of identifying what aggravated it. Like I said before, a lot of these are repetitive stress injuries, and so if they continue to do that motion or activity that aggravated it, it's not going to get any better. So if you you really want to identify what caused this and try to avoid that. Now, that means that we want to rest the area. That doesn't mean that they need to be out of work forever or even for a period of time. This is where workplace modifications come in a lot. So if you can identify what kind of caused the problem, you stay away from that, but you can still do other activities. It's better in general to keep people active. Ice can help initially. Non-steroidal anti-inflammatory medications are indicated. Injections are an option as well, not for everybody. You don't always need to jump there. I do have a slide regarding some injections coming up, but usually in general, I tend to use injections if they can't progress with physical therapy, or if they're in just so much pain that it doesn't look like therapy will be helpful for them, just because their pain is limiting them. But I do feel that in these particular injuries, early referral to PT or OT, occupational therapy, is warranted. Again, I'll talk about this a little bit on a further slide. But just the education portion of the PT, I think, is helpful, whether they can do a whole lot actively initially, but they can help guide the activity modification a lot. And then bracing is another thing to consider with this in certain areas. So if you look down at the bottom here, this is a patella tendon strap down on the left. That strap, and then the one over here at the elbow, is more for lateral epicondylitis. Those straps are really used to try to put pressure in one area to decrease pressure where the tendon is actually attaching to the bone, and can be helpful. Sometimes not acutely, you want to kind of rest things, but as things progress, those can be helpful to take pressure off the area. Over here, immobilizing the thumb can be helpful to try to decrease stress if you're having issues with that thumb area. But with my little X on the shoulder brace here, in general, putting people in a sling for a shoulder injury is not the greatest idea. So I don't see it that often, but sometimes people will go to the ED and they'll show up here and they've been in a sling for 3-4 weeks. Unless that shoulder's dislocated, broken, or you have some type of tear, immobilizing that shoulder is going to make things a whole lot worse. Immobilizing a shoulder injury, especially if it's just a bursitis or a rotator cuff tendonitis, can lead to adhesive capsulitis. The shoulder tightens up, and then you may be talking from going from a 2 to 3 week recovery or 3 to 4 week recovery to 3 months to try to get that frozen shoulder reversed. So you got to be cautious with some certain bracing. Mobility is a good thing. So next slide there. So as far as physical occupational therapy, they are two different schools of thought. There are two completely different professionals. Like they said initially, I was a physical therapist. I practiced for 2.5, almost 3 years before we came out. In general, you tend to see physical therapists treating more lower body, back, neck. Occupational therapy tends to be more kind of elbow down to the hand. Now that's a generality, but all will say occupational therapy doesn't do backs and lower extremities. Physical therapists will say they can do everything. So it all depends. But for different types of things, a different therapist may be better. But what they can do for the patient early on, for the painful region or painful time frame, is they can use modalities like ultrasound, can increase blood flow, kind of help with pain relief. They can do some cross friction massage, which is an example on this picture on the upper right hand side. So even if they can't do any aggressive stuff initially, which is not indicated early on, they can do some things to help quiet down that pain. And like I was saying before, I think that they're invaluable as far as being able to spend a lot of time with the patient and talk about, hey, what were you doing that made this hurt, and how can we modify things so that you don't do it again, even while they're at home. So they have more time with them over, because usually they're being seen once or twice a week, at least, 30-minute visits. They have a lot of time to really develop a relationship over the short term, and it can be very helpful. With time, with these tendinopathies and things, you do eventually progress to strengthening as the pain decreases, and trying to eventually get them back to work status. And so that's another interesting venue of therapy where we can use work conditioning, which is not just traditional therapy, but it's more focused on job-specific tasks. So, for example, if somebody, a lot of the times I see people, they're feeling better with regular therapy, but then they're like, oh, my pain's better, but what happens when I go back to work and it just happens again? So sometimes you can use that to help transition them or gain some confidence that they'll be able to do what they need to do. And that can be used for all sorts of injuries, not just for tendinopathies or soft tissue. Next slide there. So yeah, as far as steroid treatments, depends on where the problem is, but we can use steroid for injections to help decrease inflammation. The idea really is to decrease pain and by decreasing inflammation, and help patients progress. Like I said before, I usually use it if they're in a lot of pain, or if it looks like their pain is going to hinder their ability to progress with therapies, then a shot is something that I would consider. The pros are, like I said, decreased pain, decreased inflammation. The cons, risks are very low as far as infection, bleeding. One thing to keep in mind with these things, though, is there is potential for tendon rupture. If you have an angry tendon and you inadvertently inject directly into that tendon, you can rupture. So that's something to consider. And so if we're trying to do a shot in and around a tendon sheath, there are options to do with imaging like ultrasound that may help us guide things a little bit better. There's also the potential to flare the pain in the short term. So these are all things that we discuss with the patient before we do anything. And the next slide there. So another unique injection technique that's out there, it's been around for a long time, but in general, it's gained more traction in literature as well as in practice, is platelet-rich plasma injections. So basically what that is you draw blood from the patient, you put it down in a centrifuge, which spins that blood down. It helps us get that platelet-rich portion of the blood, which has a lot of growth factors that can promote healing, and then you inject that back into the painful region. It's not just for tendinitis bursitis, it's been used for joint pain. There are certain clinics like Regenix out there. There are people that are putting it everywhere. I don't know if that's indicated by any means. I've seen people go in and get it injected into discs, into spines, and I think that that's a little bit too aggressive as far as where the research is. But the idea is it can decrease pain and hopefully improve healing. So rather than just decreasing inflammation, the idea is that it can help regenerate or help to really promote healing of the tissue. There are cons to everything, right? The big con is the expense. So as far as private insurance, there's really no private insurance that's covering it. So it's an out-of-pocket expense. As far as workers' comp, from what I know, I believe there are some states that are covering it. I have seen a patient go to Vermont, and I think that it's a covered procedure in Vermont. I'm not positive it is in Massachusetts. I don't believe so. The research in general is not completely conclusive, but there is some good, dependent on region, some good backing to it. It looks to be good for lateral epicondylitis. Outside of the scope of this presentation, it does look to be fairly good for knees, for arthritic knees. But it's tough to compare study to study because everybody uses a different protocol, everybody uses a different machine, so it's hard to really to gauge that in the literature right now. But it does show promise, and in general, it is under the umbrella of regenerative medicine, which does involve stem cells. Platelet-rich plasma is not stem cells. Stem cells is a different thing altogether, but it is a unique treatment that is something that you wouldn't use right away, but can help a lot in these types of injuries. Next slide there. So in general, I think that the key factors for these types of patients in their recovery and their return to work, number one is that early identification. The patients I have the hardest trouble with, is they've gotten injured at work, they've gone to an urgent care, they've been told they have a strain, they just say, ice it, rest it, and and for a lot of people that's all they need. It gets better, but then by the time they see me, it's things are still getting worse. But now it's been 3 months, and so something that may have, with more earlier therapies or earlier treatments, could have gotten better in a few weeks. Now we have a lot of other things that come into play. The muscles get tighter. They might have coinciding neck pain now if they have a shoulder injury. So early treatment and identification, I think, is key. You want to avoid what's getting worse. So whatever made it hurt, you want to stop doing it. But people need guidance in that, and I think that we can provide that in our visits, and physical therapy can help that as well. Again, I think early PTOT is good for all of the things that I mentioned prior. And so if you get these things treated, these can get better in a matter of weeks rather than months if you kind of get on top of it. But like I said, some of the pitfalls really are just delayed treatment. And so if things get hung up, or they've been referred to therapy and then things don't happen, or they don't follow up or something, and just a lot of time passes, that can be a problem. Whereas if you just jumped on it, things could have got a lot better quicker. Next slide there. And then just to touch on one more thing here, injury prevention, right? If you don't get injured, then we don't have to treat you. It's not great for business, I suppose, but it's something you want to talk about, or we try to talk about to a lot of our patients. So ergonomics at the desk. Right now, I'm sitting in a horrible position. I talk to people about ergonomics at the desk all day long while I'm hunched over my laptop. But it is important. If you're going to be doing something for long periods of time, you need to be in a position that's not going to injure you. And then continuing home exercise, having some type of exercise routine, especially if you work a physical job. I did my residency in Dallas, Texas. If anybody knows anything about Texas, they are always doing construction. There's always a new high rise or some highway going up, and I took the train in every early morning, and when you'd go through, you'd see all of the construction workers standing around doing stretches, and they looked like they were getting ready to play football or soccer. So if people warm up before a physical job, that will help decrease injuries in the long run. So you really kind of, if you could say ahead of the injury, it's better than trying to treat it. But yeah, just something to touch on there. And I think that's it. Yep. Any questions there?
All right. Awesome. Thank you to all of our doctors for sharing such a wealth of information. I know for this kickoff session, we really wanted to touch on the top 3 injuries that are seen in workers' comp, and so we did push a lot into this. But now here is your opportunity to submit your questions. So please go to the Q&A feature within the dash, and I'll moderate your questions and try to figure out which physician you're pointing them to. If I get it wrong, just let me know, and I'll try to point it to the right one. To kick us off, though, we do have a question, and this one will be for Dr. Cooper. And this is, what are the statistics regarding outcomes?
Spinal cord stimulation, otherwise known as neuromodulation, is something that we reserve as a last resort when everything else has failed. So obviously we're dealing with a very difficult population in that sense. But in general, the studies find that about 2/3 of the patients who have a spinal cord stimulator trial, which is a kind of a test run where we put wires in percutaneously and try it out. It's the only surgery I know of that you get to try out before you commit to it. So about 2/3 of those patients who have a trial have at least 70% improvement in their symptoms and decide to go forward with permanent implantation. And about 2/3 of the patients who have a permanent implantation and end up reporting good or excellent results. So considering the population, that's a really, those are good numbers. I can say in our program, our numbers are a little bit higher than that, more like 70 to 75% of patients who have trials go on to permanent implantation. And about 2/3 to 70% who have permanent implantation are glad that they did.
Awesome, thank you. So here's another question, and we actually want to ask this of all practitioners, but we'll start with Dr. Watson. In general, like, what's your philosophy regarding return to work and injuries?
My philosophy regarding return to work and injuries. Return to work as soon as possible, keep them working in some capacity, and avoid re-injury. So as much as possible, keep them doing something modified, but keep them working. So that's it.
Thank you. Dr. Davidson?
Yeah, I would kind of mirror that. I think there's very rarely do I have people out of work completely. I think the only time I really ever have that is if I'm concerned with something severe is going on and we don't know what it is yet, and so I'm waiting on imaging. You know, but for the most part, yeah, some degree of work I think is good, even if it's just getting them up and back into the workplace. Just staying on a schedule is good for people. There are studies out there that show, you know, the longer you're out of work, the less likely you are to ever return. And there's always something that you can do. Now that sometimes we hit a roadblock there where we have restrictions and the workplace doesn't have anything for them to follow within those restrictions. But I think keeping people mobile and staying in work to some degree while protecting their injury is the best way to go about it.
Can you all hear me? It looks like Gigi, we're having some sort of technical difficulties.
I can hear you.
You can hear me? Okay.
I can hear you.
Okay, so while Gigi's working on straightening that out, I have to say, in the last year and a half, we've gotten really good at Zoom calls and being able to communicate this way, but things do happen at times, and especially since we've got practitioners that are calling in from different places. So if you could, maybe someone could answer this question. What are your thoughts and protocols regarding narcotic use for cervical and lumbar injuries? What do you usually do in your practice? And I know that's a very general question and every patient's different, but can you give us your thoughts on that?
Well, I can say that the pendulum has really swung from when I started practicing. At that time, you know, pain was, you know, was one of the vital signs, and if somebody was unable to return to their usual activities because of pain, it meant that they weren't getting enough narcotic pain medication, and those were the heydays of OxyContin and other oral opioids. Obviously, we don't feel the same way anymore, and our approach is that we minimize the use of opiates. It generally complicates the clinical situation, you know, it's always a very difficult balancing act. We want to be humane. We do what we do because we want to make suffering minimized, and we want to reduce patients' discomfort. But on the other hand, opioids don't seem like the best way to do that in most cases. We do have a small population that just has no alternative. You know, I had a patient this morning who's 90 years old, and she's shut in at home, and she has horrible spinal disease and deformity and chronic nerve damage and radiculopathy. And yeah, and she's, and I've been maintaining her on opioids for years now. But we're very judicious about their use.
That's good to hear. That's good to hear. Does anybody else want to add anything to that, Dr. Watson or Dr. Davidson?
Yeah, I think I would agree. I can't actually add more. That's it.
Okay. All right. How about you, Dr. Davidson? With soft tissue injuries, do you find that narcotic use is needed
No, not typically. Someone has a strain or sprain. Now there are lots of people that ask for it because, especially if they want to get back to work, it's not because they're drug seeking so much. Sometimes they just say, "Give me something so I don't hurt, so I can get back to work." But that's not typically the best pattern to get on. I find so. If we can get that pain controlled through other measures or different medications, I think that's a better long-term solution.
Thank you. Now, I don't hear Gigi chiming in, so I'm just going to keep going with this, and I'm going to ask you a loaded question here because I know the answer. I've worked with these physicians in this office for years and really value them. And so in regards to treating patients, obviously workers' comp can be very challenging in so many ways. And you've heard me say for years how frustrated I am when you go into appointments and all of their focus is on the work status. Really, focus in appointments should be about treatment, and we should be then, the work status or functional status is important. Is there anything you're using in your practice to educate patients about what their functional status should be throughout their recovery period? And that is a loaded question. Go ahead.
I think in my experience, I need to make sure that the patients understand that the restrictions that they're being given at work are the restrictions they should also be following at home. I think there's a misunderstanding, or at least it's been my experience, that they can follow the rules at work, but then come home and do some landscaping. So I'm gonna tiptoe around that subject, but yeah, that would be my 2 cents.
So really the focus.
All right, I am back, everyone, just in case. Sorry about that. I just lost audio completely.
That's okay. So Dr. Cooper, would you like to answer that question? Because I know that you do something specific, that you're using a certain pathway that you educate patients on. Do you want to just bring that up?
Yeah, well, we've worked on those pathways, and you've been instrumental, really. But we found very helpful, and I kind of alluded to it when I was talking a little bit earlier, that patients they do better, and we can reduce the length of their disability by setting expectations up front. So if somebody has an injury that prevents them from doing everything that they normally do with their job, then it's our job to specify what those restrictions need to be. And it can't just be arbitrary. There has to be a reason for the restrictions that we set. And it also helps for patients to have an idea of the timeline by which we expect them to be able to normalize their function, both at home, as Dr. Watson said, and also at the job, so that they should leave the first appointment with an idea of what's wrong with them, what's the prognosis, what's the natural course of this condition, what the treatment plan may be, and roughly what the timeline is for reducing those activity restrictions and finally getting them back to what they were doing before the injury happened.
So if I could explain a little specifically, so what these doctors have done is for certain diagnoses, they've outlined what the treatment plan is throughout the course of their treatment, their anticipated treatment plan, and they've educated the patient about that. And then they've given them a functional status note or a projected work status note, which outlines what their goals are through their treatment period until they're all better, which I think is pretty innovative of this office to be able to do that. It's really hard when it's easier with surgeons to give an expected return to work full duty note. It's harder when you've got musculoskeletal injuries and spine injuries where so many things can interfere with that. So I find they do a really good job regarding educating their patients regarding that. Gigi, I'm going to let you take over.
All right. Well, if there are no more questions, I'm watching the queue. We'll go ahead and move forward. We're just at time. So thank you for joining our first session of the Injury Insight series. Please keep in mind this is a 4-part series. And our next session is June 24th, a joint effort managing the road to recovery in knee injuries with Dr. Sean Rocket. A password protected playback of this webinar will be available within about 48 to 72 hours. Additionally, we do ask that you take the time to complete the webinar survey. It gives us valuable feedback on what we can add in the future or things that we maybe could do better for the series. Finally, certificates of course completion will be emailed to you within 5 business days. And again, I want to thank our physicians. Thank you for sharing your knowledge. We really do hope that our attendees have found your information helpful. Our goal here at MLCC is to really continue to be the advocates for the patients, and we know that you do too as claims adjusters and claims professionals, and understanding the injuries a little bit better, we hope helps you to do that. Thank you again for your participation, everyone. Have a great day.